discuss the costs and benefits of electronic health applications. Electronic health applications include the electronic health records, EHR, computerized physician order entry, CPOE, and clinical decision support system, CDSS. EHR is a paperless form of the medical record that requires the healthcare provider to enter patient information into a computer system. CPOE is a technology that allows physicians to enter orders into a computer. CDSS is defined as any software package designed to directly aid in clinical decision-making in which characteristics of individual patients are matched to a computerized knowledge base. Let us discuss EHR and its costs first. Researchers estimated a total project cost of approximately $19 million for a 280-bed hospital. In the ambulatory setting, estimates of the initial costs are $50,000 to $70,000 for a 3-physician office. Overall, the specific cost categories include hardware, software, implementation, training and support. Last but not least are the costs due to temporary reduction in staff productivity. One estimate of the expected productivity loss is 20% in the first month, 10 in the second, 5 in the third, with productivity returning to baseline levels subsequently. The literature suggests that most of the benefits from using EHR fall under one of the following categories: increased revenues, averted costs, or other less tangible benefits. First, increased revenues can be realized when implementing EHR by improving charge capture and decreasing billing errors. Second, averted costs are realized when an IT intervention restructures workflows in such a way that some costs associated with the previous way of conducting business are eliminated, reduced, or replaced at a lower level. Here are the few categories of these averted costs. Many additional benefits are difficult to quantify financially, but can be realized by utilization of an EHR. First, improved quality and outcomes. Researchers have shown better infection control, improved prescribing practices, and improved disease management in the hospital setting, and improved practice immunization rate in the outpatient setting. To name a few other less tangible categories include improved patient safety, improved patient education, improved coordinations of care. Now, let us discuss CPOE and its costs. Typically, they include technical development, process redesign, implementation, and support costs. In the absence of a major network upgrade, the cost estimates of a 500-bed hospital are approximately $8 million, with an annual maintenance cost of $1.35 million. Despite the mentioned sizable investment, CPOE can reduce medical errors. Research has shown that a 55% reduction in serious medication errors is possible when using a CPOE. When CPOE is linked to a decision support system, a reduction of as much as 83% can be achieved. The reduction in medical errors is largely due to CPOE providing accurate, legible, and timely orders that have been checked for errors. Other categories of benefits include drug interaction checking, improved compliance with dosing guidelines and formularies, improved charge capture, improved workflows, and productivity. Let us now discuss CDSS. There are many different applications which can be as simple as a small software program that checks drug dosing on a CPOE, or something as elaborate as an automated alert generator for clinicians. Therefore, it is difficult to generalize their potential costs. On the other hand, CDSS can reduce length of stay substantially by utilizing clinical pathways for a given treatment regimen that is more likely to get a particular patient well quickly, and thus reduces costs and increase hospital capacity. Here are other benefits of CDSS. Having discussed all the costs and benefits of electronic health applications, how do it work in the real world? In response to the landmark 1999 report by the Institute of Medicine, the Children's Hospital of Pittsburgh implemented CPOE in an effort to reduce medical errors and mortality rate. To test the hypothesis that CPOE implementation has resulted in reduced mortality, Khan and colleagues performed retrospective analysis of pre- and post-CPOE implementation time periods. The univariate analysis revealed that mortality rate significantly increased from 2.8% before to 6.6% after implementation. The researchers cited the following issues as contributing factors: difficulty in placing orders, inability to timely register new admissions, inability to obtain medications in emergency situations, inability to pre-order medications and imaging studies, and lack of communication between nurses and doctors. In response to the previous study, Del Baccaro and colleagues set out to determine if there were any changes in risk-adjusted mortality after CPOE implementation at the Children's Hospital and Regional Medical Center. These researchers found that the pre-implementation mortality rate was 4.22% and the post-implementation mortality rate was 3.46%, which is a non-significant reduction in the risk of mortality. They concluded that careful design, build, implementation, and support can mitigate the risk of implementing a new technology, even in the ICU setting. Specifically, the researchers asserted that the implementation issues, such as more order sets and ability to get medication directly in emergency cases, rather than the inherent issues of CPOE itself, are the primary risk factors affecting mortality during the implementations of CPOE. Overall, three conclusions can be drawn from all of the above studies. First, EHR, CPOE, CDSS hold great promise as tools to reduce costs and human errors. Second, institutions must evaluate mortality effects directly in addition to surrogate outcome indicators, especially for time-sensitive processes such as ICU settings. Third, negative impact of technology change should be distinguished from systematic error caused by old paradigm having not shifted to meet the needs of new technology.